thank you for coming along to this session. And I'd just like to welcome to you Angela Newbound and Claire, and they're going to run us through this session. They're going to do one section each, one under 65 and then one over 65, and they will have questions throughout the presentation. So I'll hand it over to them. Give them applause, please.
Thank you very much, and certainly thank you to Sanofi for inviting me to present today. Just a small conflict that I need to declare is that I do sit on the advisory board for the Immunisation Coalition and have certainly been involved with the advisory committees of the Jigsaw of Influenza Advisory Committee as well as the Zostavax Advisory Committee. So just a little bit about me. I've been involved with the immunisation program now for 19 years, and here in South Australia I am the coordinator of the Immunisation Hub, which is both primary health networks have merged their immunisation programs together, so we've got a statewide focus on immunisation. So I coordinate the hub, but I am here today in a capacity under my consultancy of immunisation education consultant. I also work one day a week with the Benchmark group that are about to have this wonderful immunisation course available for nurses in primary healthcare. So they are all the hats that I wear that I can now say that I've declared. Oh, am I meant to have done something? Just click
on your name. Sorry, I just got to gum your fingers if I get right.
There we go. Good. Thank you. So just a real snapshot of the presentation that I've been asked to deliver today is really just about the jigsaw of flu over the last 20 years here in Australia. So we'll look at the brief history around vaccinations, particularly around flu, what's happening, what's new for 2019. So there's been a couple of changes. What vaccines are going to be available in Australia for providers to be offering to their patients or clients, as well as what are the remaining challenges? Because I think, who's been to a flu session already where flu's been mentioned? Flu uptake is what? About 75. That's in Claire's realm of the over 65s. Any guesses for underneath? Well, we'll talk about that. So we've got some challenges there for sure. And then it's about, what's sort of going forward from there. So this is a sort of a bit of a timeline for flu vaccines in Australia. So you can see really very late in the piece did we actually have a national influenza program that was funded for individuals over 65. So we haven't been vaccinating a real long time, have we? It really only has been just over 20 years as a funded program. 2009. Who was around in 2009? So you experienced a little thing called swine flu, did we not? So it was a little mini pandemic, wasn't it? It was a little bit of a practice run for our pandemic. It wasn't a true pandemic as pandemics are really truly categorised. But it certainly stirred up some activity, didn't it? We had a lot of people contract flu, we had a lot of people really, really sick with flu, and we certainly saw 191 people die directly related to that H1N1 outbreak. So they had to stem this outbreak very, very quickly. So there was a pandemic H1N1 flu vaccine that was released, but initially for the older people, so the 10-year-old and upward. But it wasn't long before that the paediatric data started coming in to say that this vaccine was actually going to be quite safe and effective for children less than 10 years of age. So we've progressed along since then, and 2009 really taught us really significant lessons about how dangerous flu was for certain individuals. And one of those groups definitely, was children, but definitely pregnant women. So flu and pregnancy just are an exceptionally bad mix, and we just cannot have pregnant women contracting flu at any stage of their pregnancy. So the 2010 program saw flu vaccine then funded for a wider range of patients. So by the end of 2010, the seasonal influenza vaccine that had been released covered the H1N1 strain, so therefore the pandemic H1N1 vaccine program could then cease. So coming into sort of the mid-noughties, I suppose they call them, they started funding vaccine for Aboriginal children, which was absolutely great. Quadrivalent vaccine. Now this was very revolutionary because up until then we were only using a trivalent vaccine for all age groups, etc. So the quadrivalent came in and that was pretty popular. Everyone thinks that getting something extra is a really, really good thing. It wasn't adverse at all. Everyone wanted the 4-strain one because they thought, yep, this is great, that 4 is better than 3. So, and it definitely was. But then the problem that we saw in 2018 when we actually went back to having a trivalent flu vaccine available for our over 65 population, then we had a little bit of a problem because the over 65s thought they were missing out on something, and so they were all wanting the 4 one. The 4 one's better than the 3 one, and we're going, no, the 3 one's better than the 4 one for you. Claire's going to talk about TIVs and the over 65s shortly, so I'm not going to harp on that. But, you know, it would have been a challenge, certainly for the providers. 2018, so last year, a lot of the states and territories, almost all states and territories, funded a flu program for young children. We know that on the NIP for Aboriginal children, they were having funded vaccine from 6 months up until 5 years of age at that stage, and then again from 15 years onwards. But there was no funded program for non-Aboriginal children. So almost all states and territories last year came on board and did that. And that's sort of going to be pushing a little bit of pressure onto the Commonwealth to be really thinking, you know, should they be funding under the National Immunisation Program flu vaccine for all children? So we'll wait and see. Recent news, January this year, obviously the announcement was made that there was going to be an expansion to the flu program for Aboriginal children, and they did actually realise then that Aboriginal people aged 5 to 15 actually did get flu. So we might as well give them free vaccine as well. So now, thankfully, all Aboriginal people from 6 months of age have access to free flu vaccine. So that's an absolute good news story. So I think, you know, how many thousands of times have you seen this particular slide? Probably many, many, many. But, you know, I think the thing to highlight with this is flu is exceptionally underreported. And I think when I ask people questions about, you know, who's had true flu, you know, diagnosed flu, and, you know, half of a few hands go up. Yeah, thanks, yep, you've got a few. You know, but then I often will ask people, you know, that's great, how sick were you, all of those sorts of things. But, you know, I think probably the next question I should be asking people is, who has not been swabbed for flu? Because when I see people who've got 20% of the room with their hands up saying, yeah, I've had flu, I would probably guarantee that the rest of the 80% in the room actually have had flu, but they've just never been swabbed for it. Because if you've been listening to John Litt's talk and came to our session yesterday, flu can be asymptomatic. You actually don't know that you've got the flu, but if we were to swab you, we may find it. You might think you've got a cold. If we swabbed you, it might be flu. So the fact that we're not swabbed all the time doesn't necessarily mean that you've never had flu. So very, very underreported. You know, Claire will certainly talk about the more critical complications, etc. But, you know, even to try and ascertain how many people die of flu every year is really challenging because of the way it's coded on death certificates at hospital level. So we don't get a really true picture of how dangerous this disease is. So what's new 2019? Beginning of March, the Chief Medical Officer of Australia released his letter explaining that they're going to be having all of these extra millions of doses put into the National Immunisation Program, which is fantastic given the uptake of flu vaccine last year. Remember last year we ran out of vaccine by the end of April, and we were in a little bit of a pickle. Aboriginal Torres Strait Islander children from 6 months and upwards are eligible. Certainly recommended for everybody else, but not funded. But it's a cheap vaccine. You know, this is not an expensive thing to be asking people to do. Pharmacists are out there about $13 for a quadrivalent vaccine. You know, they're accessible, they do it well, you know, so let's use them. So obviously there were some strain changes as well. We've got a different A strain and a different B strain in the quadrivalent vaccines this year. In regards to South Australia, who's a South Australian provider here? So so there's a few of you. You were aware that SA Health have released Fluad already because of our outbreak here. We've had around about 3,700 notifications since the 1st of January through to the 31st of March. We've had one death of an 89-year-old individual, and we've had outbreaks in aged care facilities. So SA Health made the decision to allow providers to start vaccinating the over 65s. So they released that program early, and news came out yesterday. SA Health have sent an email to providers saying that you will now be able to order your vaccine for the rest of your cohorts as of Monday. So have a look at the vaccine notice board, and they have released all of their flu schedule and their flu ordering information, etc. So when I'm in the office on Monday, I'll certainly be sending that out through the immunisation provider network. So other states and territories are managing their program as well a little bit differently. Who's here from New South Wales? Yep, and so what's happening in your state? Not much, Danny? Not much. Crickets. So South Australia, we're on the good foot, absolutely. Oh, fantastic, okay. Excellent, and you know, this is a little bit interesting because there's still no CMO, there's still no ATAGI statement. I've been looking 24 hours a day on my phone and there's still no ATAGI statement. So that's really interesting that states and territories are going ahead with their program despite not having a ATAGI statement. So we're still waiting for that to come, and we'll be pretty pleased to see it. We're hoping it's going to clarify a few questions. We know this question around should people get 2 doses of vaccine in the same year? I mean, we get asked 1,000 times, and the question mark is still there. Look, it's not contraindicated, of course, but there's no recommendation for it. You know, it's a bit watery, isn't it? So providers sort of really don't know what they should be doing. So if we are looking also what's new in 2019, just very, very recently they changed the guidelines around pertussis vaccine for pregnant women. So we're now vaccinating from 20 weeks. So ideal time is 20 to 32 weeks gestation. But use these opportunities to immunise them against flu as well. Okay. So very safe to be given at that gestation. If a pregnant woman I'm just going to divert a little bit here, but if they do get their pertussis vaccine before 20 weeks, you do not need to repeat it. All right? If they haven't had their pertussis vaccine and they're over 32 weeks, they can still have it right up through to delivery. So, but definitely opportunistically grab them with flu vaccine at any stage of their pregnancy. We don't want pregnant women getting flu in early pregnancy because the fever that they get as a symptom of flu certainly has been linked directly to congenital abnormalities, such as cleft lip and palate, all right, neural tube defects. So we don't want them getting a fever because they've got flu early in pregnancy. And what we learned in 2009 is the further along they got in their pregnancy, if they were to catch flu, the complications rose, the ICU admissions rose, and the fact that they would probably die also rose. And there were pregnant women around the world that were 2 weeks shy of their due date dying. of H1N1 in 2009. So we definitely don't want pregnant women getting flu at any stage of their pregnancy. So the vaccines that are going to be available. So where I've got Flurex Tetra query NIP, we can actually remove the query. There is now Flurex Tetra on the NIP for babies aged 6 months to less than 3 years. So it will sit alongside the Flu Quadri Junior for that age group. Obviously, Influvax on the private market only. Fluad has been the vaccine to put on the NIP for the over 65s, so that's the adjuvanted vaccine. Fluzone, which is the high dose, has been put on the private market, and Claire will be expanding on that very, very shortly. So just providers, be aware, 7 different flu vaccines around, 5 different age groups. How many vaccine checks do we do before we administer? So at the fridge, when you first get your flu vaccine out, make sure it's the right one for the right age group, just before you administer to the patient, all right, as you're preparing it, and then just as you're about to put that needle in, just do one last check. Because like I say to nurses all the time, once we put that vaccine in that arm, we cannot suck it back out again, okay? So make sure you've got the right vaccine. It's a risky program, and there's a huge risk for error. So let's look at the kids under 5. Anyone got a problem vaccinating kids under 5 against flu? Parents pretty willing to have it done, or is uptake relatively low? It's getting better, so there's a bit more information around about it. Okay. So I think what we need to... The doctors, now, bless them. Have we got any doctors in the room? No, look, there was a little bit of a scare back in 2010, wasn't there, with children having flu vaccines and having high fevers, and some of them went on to have febrile convulsions. So there was a real challenging period in 2010 over that. And it did sort of put a lot of providers off from saying, look, this isn't a safe vaccine for kids. It is a safe vaccine for kids. But what we do know is children receiving flu vaccine, you know, when an adult receives a flu vaccine, some people feel like they're coming down with the flu. You know, they feel a bit lethargic and they feel a bit achy and they've got a fever, and that's when they say, oh, I catch the flu every year from the vaccine. No, they don't. But anyway, it's a little side effect. So just remember in young children that those symptoms are exaggerated. All right, so if an adult's feeling achy and unwell, a child will feel more achy and more unwell. So they are very responsive in that way to the vaccine, and therefore they do have those high fevers. We must then talk about fever management and fever identification in parents. This is not how you identify if your kid's got a fever or not. All right? So it is about, do you have a thermometer at home? Because we need you to take your child's temperature if they look a little bit flushed or unwell. Have some paracetamol at home, okay? And manage their fever. How often should they give paracetamol? Make sure they follow the dosage instructions on the box, okay? So we really need to talk hand in hand about fever management when we're giving risks and benefits to parents in regards to flu vaccine for children. Because flu vaccine in children is really important. You know, when you look at the statistics around children and flu, they're hospitalised with flu more than any other vaccine preventable disease. If we wanted to put pertussis and Hib and chicken pox and all of those sorts of things together, more flu hospitalisations. We do know that if we look at a J-curve in relation to flu in children, it's really, really high, and then it comes down as we get a little bit older, and then it heads straight back up again for our elderly population. And if we were to look at hospitalisation rates from flu, it's very, very similar. We've got high rates in children, scoops down, and then it bounces up high for older individuals. So they are our two endpoints in regards to hospitalisation rates. So definitely they're overrepresented. But bear in mind, children don't have to have a chronic medical condition to be at risk of severe outcomes of flu. They're quite often really healthy children. And if you want to actually see some really heart-wrenching video stories, who was at the meningococcal session today? Heart-wrenching, yes? And when we hear these heart-wrenching stories, it makes us stand up and actually take some notice. And there's a website called Families Fighting Flu. If you want to go on there, they'll be talking about the children that they've lost to flu. Right? And it is heartbreaking. So these are healthy young children. So the challenges around this is, what are our options to stop children getting the flu? We can just enforce mask wearing for this age group and see how we get on. Probably not very well. Or we can immunise them, which seems to be a much better option in my book. So nationally, uptake is actually really difficult to define. We don't really have very good data, and sometimes I think this is where one of our challenges might be, is that we don't have readily available data. So children that are under 5 years of age, immunisation rates we know recently have actually improved over 2018. Was that because we had a horror season in 2017? More parents saw their friends or family members getting flu in 2017, so that made them stand up and get their children vaccinated? Is it because states and territories were running free programs? Quite possibly. I think it's a multi-layered strategy that's working. For South Australia, for children under the age of 5, there are around about 30,000, just 30,000 and a half children vaccinated against flu that were notified to the AIR. So barriers, I think, really are the lack of a funded program. States and territories are doing a great job, but until the Commonwealth recognises that this is important, often parents won't recognise it's important. And John touched again this morning on the fact that, if it's not funded, a lot of people don't believe that it's that important. Well, the government don't take it seriously, so why should I? All right. So, getting vaccines on the funded program is really essential for a successful immunisation program. I don't envy government. They've got a public purse, it's taxpayer money. They've got to be responsible to where they put that. But, this is a really costly program, so it's something that we should be aware of. Lack of provider awareness. Absolutely. When should I be offering this vaccine? Does it work in children? Is it not the best thing for children to have? But it's also lack of provider awareness, parent awareness as well. So lots of missed opportunities when these kids are presenting to general practice. We know that kids present to general practice around about 6 to 7 times a year. So there's opportunities for them to be vaccinated. As long as they're not febrile on that particular day, we can be vaccinating them. So it is about having conversations with every single person that you engage with at your practice about, hi, my name's Angela, I'm the practice nurse that's on duty today, and we're going to talk to you today about flu vaccine for you and your children. So don't even let them say no to the conversation. They can say no to the vaccine, but, if they have the conversation first, maybe they won't say no. So we've certainly progressed though. Providers are vaccinating clearly. There's data on the register, which is excellent. I think the other thing with children too is the fact that, flu's a bit unsexy, isn't it? Like, it doesn't hit the front page of the newspaper. We get a meningococcal case, which is devastating. I'm not understating that. But it hits the front page of the newspaper. How many children have died of flu in Australia last year? Because it didn't hit the front page of the newspaper. Nobody's aware of it. So the media is not our friend, really, when it comes to really talking about flu and the impact in the community. So, healthy adults. How's your uptake with healthy adults? Do you talk about it with healthy adults? Good, that's good to see. A colleague of mine at the Adelaide Primary Health Network, he's a 32-year-old gentleman, he's very, 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 very fit and healthy, missed our staff flu vaccine day. So he said, that's fine, Angela, I'm going to be actually going to my GP for something else, I've got an appointment next week, so I'll grab it then. And I said, that's great. Goes to his GP and says, oh, actually, while I'm here, I'll grab a flu vaccine as well. And the GP said, why? You're a 32-year-old and you're healthy, you don't need a flu vaccine. And he said, oh, yes, I do. And he said, no, you don't. And he said, yes, I do. And he goes, why do you think you need a flu vaccine? He said, because I work with Angela Newbound. But, you know, for those of you in South Australia who know me, but even that wasn't enough to actually sway this GP. And my colleague walked out without a flu vaccine from his GP because the GP had made the decision that that individual shouldn't need a flu vaccine. And that is a good point. It is not the decision of the provider to make to whether or not someone gets a flu vaccine. Our role as an immunisation provider is to give all the information to somebody for them to be able to make the decision whether they choose to vaccinate or not vaccinate. We're there to vaccinate them if they say yes, but our real role is actually to give them information, not to make decisions. So our healthy adults are a little bit of a problem and they slip through the net pretty quickly. Data, once again, really, really poor. So 2009 was the last adult vaccination survey. What did that show us? About 23% uptake for flu in this age group of under 65s. So clearly not good enough. So H1N1 in 2009 taught us some really horrible lessons in regards to how many people got sick with this disease, how many ended up in ICU, how many people died, etc. But look at the age group that H1N1 in 2009 affected. So I've just been spieling on about young children and older people, but it really does depend quite a lot on what's circulating around. So flu vaccine is important for absolutely everybody. So, for our healthy adults, what are our options? Send them out on a deserted island all by themselves so they can have no contact with anybody else that may have a cough or a cold or a sniffle. So we could actually just do that. We'd run out of islands, or we can actually vaccinate them. So this is even harder data to find. Try to find data nationally for this age group, very, very difficult, because it's an unfunded group largely, unless you've got a medical condition. But even those with medical conditions, and we'll talk about that shortly, uptake is not good. So unless we want to sort of measure on how many prescriptions for flu vaccine or how many vaccines the pharmacists deliver, which were mainly to the healthy age group, this middle age group that are healthy. So I just sort of did a bit of I downloaded several reports actually from the AIR, because you've got to download so many to get the numbers. But you can sort of see around about 20 to 22,000 doses in those 10-year age brackets. So that's not good uptake. When you think that's over a 10-year age bracket, 20,000 doses per age bracket, it's not good coverage, is it? So this is what has gone to the AIR last year. So once again, lack of a funded program nationally. Will we ever see funded flu program for everybody on the NIP? Is it a possibility? Is it a probability? Who would know? But it does come down to dollars, and it's still taxpayer money. So there's a lot of lack of information around, I think that's really good information for people, and this is where it's so important for providers to be able to impart good information to individuals about flu vaccine. And yes, you are going to get those resistors that, no, I got the flu from the vaccine, and no matter what evidence you want to put before them, they're not going to change their mind. And that's fine, but we keep offering it every year just the same, or every visit just the same, right? Because they may have had a personal experience that might change their mind. Social media, I'm not a lover of social media. It just tends to spread a lot of misinformation much quicker than it spreads good information. So you may need to be there to counteract that information and all those misconceptions. And we certainly miss opportunities such as my work colleague. He was right there at the GP practice. Missed opportunity. So with our at-risk groups, so we know flu is an exceptionally dangerous disease for a lot of people, but particularly our at-risk groups, and particularly those with cardiovascular or pulmonary disease. So if we look at these individuals that are less than 65 years of age, a flu vaccine in these at-risk younger individuals is certainly got a massive impact on the hospitalisation rates as well as the rate of death for these individuals. We talk about the effectiveness or the efficacy of flu vaccine, and we kind of know it's not a perfect vaccine, is it? You know, on a good year we might get 65%, 75%, all right? But it's still good. In a compromised individual, it will be less than that, maybe 50%, maybe 40% of stopping them from getting flu, but the impact on hospitalisation rates and death is what we really like to focus on, and that's a really important part. Flu vaccines aren't really designed to stop you from getting the flu. They're designed to reduce the likelihood that you'll become really ill if you were to contract flu. Okay. So we're giving the vaccine to stop that more so. So look at the rate of hospitalisations in Indigenous people as well as in pregnant women. Once again, pregnant women, we talked about this with H1N1, and we look at the admissions to ICU of pregnant women. We know that with pregnant women, we relax our T-cell pathway. Okay? So that's our T-cell pathway that really fights diseases like flu. And when we've relaxed that T-cell pathway, then we just allow flu virus to circulate around us. So pregnant women can get sick very, very quickly. Vaccinating them takes 2 weeks to build those antibodies, correct? Okay. So they are at risk of getting flu before their vaccines work. So we want to vaccinate them as early as we possibly can. So several of them certainly require ICU. It can lead on to preterm deliveries and certainly longer hospital stays. So what are the challenges for our over 65s? For our pregnant women, for our Aboriginal and Torres Strait Islander individuals, and our medically at risk, is just to get them vaccinated. Okay. Talk to them. Really find out what their barriers are and try and reduce those barriers as much as you possibly can. So Claire will expand more on why these individuals are at risk very, very shortly. So what are we going to do? What do we need to do going forward? I think we need to advocate. I think we need a voice. I think we need to shout it from the rooftop. I think we need to put a lot of pressure on politicians to make sure that this vaccine is available across the board for all individuals as much as the dollar will allow us to. For me, that means definitely all children under 5 years of age on a funded program. So it's not at risk of a state and territory funded program where if a state or territory wants to build a new bridge to the Oval, they might just decide to shut down the funded flu program to use that money to build the bridge. And that's the risk that we take with state funded programs. So going to the NIP does secure it. We need to be offering flu vaccine to every single living human being that's on this earth every time that we see them. There is access there. We've got general practice, we've got local council immunisation services that are delivering flu vaccines. We've got our Aboriginal health services, we've got our pharmacists. More and more pharmacies and more pharmacists are coming on board with this program. And in South Australia, they all give flu. All around the country, they can all give flu. What else they can give differs from state to state, but certainly all of them are delivering flu. We've got other services, hospitals, child and family health services, etc. Reporting to the AIR. We need data on the AIR. It is really useful for other providers to know whether their patients have been vaccinated by somebody else or not, but it's also important when somebody does come into hospital with really severe flu, they're unconscious on a ventilator in ICU, have they been vaccinated or not? They can get on and check the AIR. Right? So data is really important. So, and reporting flu disease, most definitely, it is a reportable disease. So going forward, you know, our flu immunisation program has certainly been a journey. Good news is I think that the journey is going to certainly continue, but hopefully just not quite as windy as what it has been. And it certainly is improving all the time, so it's definitely an onward and upward. So just in conclusion, you know, it takes a village to raise a child. You know, that's an African proverb. An entire community of people must interact with children for those children to experience and grow in a safe environment. My proverb, it takes a village to stop flu from spreading. An entire community of people must be immunised to experience and grow in an environment where flu cannot spread easily. So thank you very much. Claire. Any questions? Good, thank you.
Could I just interrupt for 1 second? I'm sorry. We've got a message to say that one of the girls working on the Pfizer stand in the hall has lost a notebook which has got very important messages in it, and she wonders if someone may have picked it up and popped it in their bag as one of the ones they're giving out. So if everyone could just have a rummage in their bag, and if they've got a blue Pfizer notebook, see if it's got anything written in it. No? Okay, great. Thanks for that. Sorry to interrupt. And I'll pass it over to you now. Thanks.
Right, thank you. I'm just checking that this one's on. Thank you, Angela, for a fantastic talk and highlighting the need to increase uptake in under 65 population across all ages and within the various different at-risk groups. I will give just a little disclaimer. So I am Medical Science Liaison with Sanofi Pasteur. My background is as a biomedical research scientist. I worked for over 12 years on a range of projects focusing around ageing, metabolism and cancer. I'm now with Sanofi focusing on vaccines and immunisation. So as Angela mentioned, the presentation I will be giving today focuses around that burden in the over 65. So the another piece of this big jigsaw of influenza that we have. So I'd just like to say, if anyone has questions at any point, please feel more than free to ask them as I'm speaking. I'm more than happy to have a discussion rather than me just talking at you. If you don't feel comfortable, of course, you can ask questions at the end of the presentation. So I'll go through the burden of influenza in older adults first. So as Angela highlighted, influenza is not just a common cold, can be a very serious disease. It can have a full range of spectrum. It can be asymptomatic. And that's a very important thing for people, particularly within healthcare worker settings, to be aware of, that you can be coming in contact with that virus, be infected, not have any symptoms, and then easily could be transmitting it to others, totally unaware that you are carrying that. And you could be transmitting it to those that are at greater risk of some of these serious complications. So when I talk about serious complications, as Angela did touch on, two of the main ones are heart attack and pneumonia. There's an increased risk of acquiring both primary and secondary pneumonia, and there's an increased risk of heart attack, and I'll go into the reasons behind that in a few slides. And as Angela also highlighted, there's a number of groups that are at greater risk of suffering from these serious complications, and that includes our younger children, our older adults, which I'll be focusing on in that over 65 group, pregnant women, Aboriginal Torres Strait Islanders, and it can also cause exacerbations in those that have pre-existing medical conditions, such as pre-existing cardiovascular disease, chronic obstructive pulmonary disease. And this leads to increase in hospitalisation, morbidity and mortality. So just to focus in on some of these numbers, pneumonia is one of the most common causes of death, particularly in the elderly. In 2017, so this data comes from our national, and I'm going to completely forget what it is, but from our Australian Bureau of Statistics, 45% of the influenza deaths had pneumonia reported as a cause of death. And as Angela highlighted and John Litz discussed yesterday, there is a big disconnect between and underreporting of the burden of influenza because of this delay in heart attack and pneumonia presenting in people following their influenza infection. So if you have influenza, you are infected with influenza, you are at increased risk of suffering from a heart attack. Well, you can be at increased risk of suffering from a heart attack for up to 1 year post having that influenza infection. And with the pneumonia, a large number of those cases happen from a secondary bacterial infection that will arise after you have come through having any symptoms of influenza. So there's not often that connection made between these complications and that influenza disease. So pneumonia was previously and is known as being an old man's disease because it affects a large number of elderly people. And it is, as I mentioned, one of the leading causes of influenza-related morbidity and mortality within this age group. So we have three different spectrums of pneumonia infection with influenza. We have a primary influenza viral pneumonia. This is the most, has the highest case fatality rate, although it's the most rare. And that will usually happen within the first 2 days. We then have this concomitant viral bacterial pneumonia that will start to occur within 6 to 7 days after having influenza infection. And then, as I mentioned, there's that secondary bacterial pneumonia that can happen. So you're infected with influenza, this changes the inflammatory state within your body, it affects the airways, making it more easy for the bacteria to habituate and take over and infect the person with pneumonia. In regards to cardiovascular disease, the influenza, again, it's not that virus that is causing the cardiovascular disease, it's the changes within the body, these changes in the inflammatory state within the body that can cause triggers for these serious complications. And so with people that have pre-existing cardiovascular disease, influenza can lead to changes within that systemic inflammation that can disrupt things, your atherosclerotic plaques, which leads to increases in thrombosis, which I'll go through in the next slide, and that can cause heart attack and stroke. And influenza can have a direct effect on the heart and cause stress on the heart, changes within those epithelial cells, which then can also trigger chronic heart failure. So just briefly, in terms of heart attacks and this propensity to clot, so a heart attack, one of the most common ways that it is caused is we have these fatty acid deposits that can form within the arteries. when the body becomes inflamed, so inflammation, such as what can occur following a viral infection with influenza, can cause those plaques to rupture. So I think many of you would have seen those ads on TV for people that smoke and then pushing out the fatty deposits within your arteries. So if you have an inflammatory state, increased inflammation within your body, that can cause a trigger for these plaques to rupture. And then what happens is your body sees that as a wound and it tries to essentially heal that. And that causes an increase of red blood cells at that site, which causes a blood clot, the thrombosis. And that can then cause to a blockage in the blood flow, resulting in heart attack, and it can also cause to dislodge, resulting in stroke. So the key here is that inflammation is one of the key links between these secondary infections. And when we talk about the over 65s, so as we age, there is an increased likelihood of someone having one of these comorbidities that may increase your likelihood of suffering from a serious complication. So that's things such as type 2 diabetes and obesity. Type 2 diabetes was once known as adult onset diabetes. So that population, the over 65s, are at greater risk in terms of serious complications, just from a standpoint of increased likelihood of you having comorbidities. So if we look at some of the actual impact in terms of numbers of deaths, in 2017 we had more notifications than what we had in 2009. So this lovely red peak is our number of notifications in 2017, and that was almost 5 times higher than what happened within the pandemic year in 2009. Now in the 2017, which I'm sure many of you in this room probably remember or are aware of the number of over 65s that were affected. And many of those individuals had been vaccinated. So here is just some data from within New South Wales institution, aged care facilities. So a number of the individuals that had been vaccinated, so despite high influenza vaccination in this group, we had a very high number of reported outbreaks. In 2017, the over 65s accounted for 22% of all laboratory confirmed influenza cases. And I think most strikingly, the over 65 population counted for over 90% of the deaths that occurred in this year. And that is over at least 1,000 adults over 65 died in 2017. And as Angela said, that number and the burden of influenza is very underreported. Now, if we look at 2018, so what happened last year? 2017, we had one of the highest notifications in over 5 years of influenza, this great impact on the over 65s. And now we look at last year and we see a very, very different season. The number of notifications was less than in over the previous 5 years. So we have a complete contrast. We have 2017 is up here, and then we have a much more milder season. That's where our notifications are down here. However, when we look in terms of percentage of impact within this over 65 population, we can see that 2017, we have around an average 4,000 patients admitted to hospital with confirmed influenza. 8.9% are admitted directly to ICU. In 2018, even though it was a very mild season, we have a reduction from 3,969 to 725. There is still 8.1% admitted to ICU. And even more striking is this impact on mortality. So this direct impact on death within the over 65 population. 2017, the percentage that died due to influenza A was around 78%. Now 2018, we had a approximate tenfold decrease in the number of total deaths in the over 65s. We went from 598 to 55 deaths. However, as a percentage, the majority of them were still due to influenza A. And so at this point, I'd just like to highlight, in terms of impact of influenza, our influenza vaccine, as Angela mentioned, we have our quadrivalent that gives protection against the two A strains, H1N1, H3N2, and the two B strains. So that's a Victoria lineage and a Yamagata lineage. Within the over 65 population, the greatest mortality and impact from influenza infection occurs due to the strain H3N2. So 2017, we had a very H3N2 predominant season, and the greatest impact was in that over 65 population. H1N1 tends to infect mostly younger children, and it causes a more mild disease in the over 65s. So when we looked at the 2018, and I don't have that data, we see a switch in the age group where there was the greatest notifications. So the last year was a mild season, the main strain circulating was that H1N1. So just moving on, some information about the vaccines and the immune response. So what we refer to, and if I refer to in this presentation, the standard influenza vaccine, I'm referring to the quadrivalent vaccine that contains 15 micrograms of hemagglutinin per influenza strain. So for each of those 4 strains, 4 types of influenza virus, the standard dose QIV vaccine will contain 15 micrograms of an antigen that will cause the body, for each of those 4 strains, that will cause the body to raise antibodies that would then bind to that particular protein on the infecting viral particle to prevent it entering the human cell and causing that influenza disease. So antibodies are the key immune effectors produced by our B cells generated from influenza vaccination and from any vaccine, of course. So as I mentioned, the antibodies that are raised, and that can be from natural infection or from our influenza vaccination, will bind predominantly to those HA, so hemagglutinin protein, on the outside of the influenza virus and prevent it from entering the cell. So the influenza virus must enter the human cell in order to replicate and then be released and is transmitted via the mucus. So when we talk about and think about how well vaccines actually work, when we look at randomised controlled trial data on vaccine efficacy, so that is our gold standard of measuring how well a vaccine or any drug for that matter works in a population. That's a very controlled situation. And so when we look at how well those vaccines work in a controlled situation, despite there being dissimilarities within those randomised controlled trials, so you've got different focus groups or age groups, the vaccine efficacy is approximately the same. So on average, it's around 60%. However, when we get into the real world and we talk about vaccine effectiveness, there is a much different picture. So Angela did touch on this, that we can have a very large range of how well a vaccine works within any given season. And that depends on a number of factors, including how well the vaccine that was developed matches the viral strain circulating within that season, the age of the person affected, underlying comorbidities. And so this data here is just giving an example from the effectiveness, so how well that vaccine is preventing influenza disease in the real world population from within the US. So we can see over the course of 13 years, the year that had the greatest protection, we saw 60% vaccine effectiveness. And in the lowest year, there was 10% within the US. So also, as Angela said, it's not a perfect vaccine. However, it is the best method we have to date for preventing influenza. And of course, trying to prevent hospitalisations and mortality from these serious complications that can arise. Now, why do we need more effective vaccines in the over 65s? Why are they more susceptible to having these serious disease and complications? So in the over 65s, vaccine effectiveness is variable, as with every age group. And we can see down here, this is an average approximation. When we go from our youngest population, there's about an average, and this is pulled from a number of sources, 50 to 70% vaccine effectiveness. And then going down within our healthy young children and adolescent and adults. Now, when we get to this over 65 population, we can see there's a decrease in vaccine effectiveness. So we're looking at 20 to 40% vaccine effectiveness. But just to highlight why this is, so this population don't respond as well to influenza vaccines. And highlighting this is the data from the 2017 influenza season, where in the over 65 population, the vaccine effectiveness within Australia against the standard dose QIV was zero. So this point estimate sitting at -3%, and our confidence intervals are stretched all the way over. So in that really severe year, we had virtually no effectiveness on average in the over 65 population. And that's one of the reasons that the government fast-tracked the introduction of the 2 new vaccines last year for that population. So it wasn't done to confuse providers, it was done in response to a public health crisis the previous year. So why is it that these individuals, this age group, don't respond as well to the vaccines? Well, it's due to a process known as immunosenescence. And I believe if anyone was in John Litt's talk yesterday, he did briefly mention this. So as a very basic understanding of immunosenescence, it's referring to the process of our ageing immune system. You can think of it as ageing immune system slightly going to sleep. As we reach 65 and over, so it's not a clear cut, you're 65 years old, your immune system is not responding as well to vaccines. It's something that progresses as you age even further. It becomes less adept at responding to new challenges. And this is for a number of reasons. Now, I am not an immunologist, and so I will not go through this figure in great detail. But what it is highlighting is that in a normal healthy adult, we have quite a large number of precursor immune cells. In an older adult, the number of these cells is less. So there is a reduction in the number of cells available that can actually then recognise the antigen that is present within the influenza vaccine, which then decreases the number of immune antibody producing cells following that vaccination. So when you vaccinate someone that's over 65, that primary response compared to someone that is a healthy adult is markedly reduced. And then the recall response is reduced also. And so this process of immunosenescence, it impacts vaccines. It reduces that ability to mount an immune response towards new antigens. And now just to backtrack, as I mentioned about, we have those 4 influenza strains. H3N2 causes the most influenza in the over 65 population. So if we focus on these pie charts down here, this is the percentage of influenza cases caused by the different of influenza A and influenza B. Of those that are caused by influenza A, so in over 65 years, 81.6% of influenza cases are caused by influenza A, and when we break that down, 82% of those are due to the H3N2 strain. And this is important to keep in mind as to the reason why we have the differences with the TIV and the QIV as well. So as I mentioned, the 2 new vaccines in 2018 were brought in by the government in response to that public health crisis in 2017. they were as a 50-50 split. And so what are those two vaccines, and how do they work to increase the immune response within the over 65s? Well, while they do have that same purpose, they do have different mechanisms. They are two different vaccines. So Fluzone High Dose contains 4 times the amount of antigen of standard dose. So as I mentioned, the standard dose QIV vaccine contains 15 micrograms of antigen per strain. The Fluzone High Dose works in that it has 4 times the amount of antigen. So it's got 60 micrograms of antigen per strain in the vaccine. The Fluad, which is our adjuvanted vaccine, contains a standard dose, so 15 micrograms of antigen per strain, and then it has what is called an adjuvant. It's an additional additive, MF59, which is an oil and water emulsion, and how that works to alter the immune response, or how those two vaccines work, is quite different. So as mentioned, they are both trivalent formulations. So why were they brought in compared to a QIV? They give this greater immune response against the H3N2, which is the causes the most severe disease in over 65 population. So if a patient asks about, well, am I missing out from not having that extra 4th strain? The impact of that 4th strain in the over 65 population, or the number of notifications, is very low. It's probably on average around 7.5%, and that comes from a paper, I believe it's the early 2000s. I'll have an extra slide around that. But it is that they are getting this greater protection against a strain that causes the most severe disease for their age group. So just to go through in terms of how those vaccines work, if you think about a healthy adult has a standard dose of vaccine, you inject them, they have an immune response, and so their immune response is up here. Now, when we inject an older adult over the age of 65, they have a difference in the number of these precursor immune cells present. This results in a reduced number of vaccine-specific immune cells and a decreased immune response. So in that over 65 population, if you give someone that's a healthy adult the standard dose vaccine, their immune response is here. If you give someone over 65 the standard dose vaccine, their immune response is down here. So the purpose of these new vaccines is to bring that immune response up here. Now with the Fluzone High Dose, the idea around that increasing the number of antigen present is that it increases the likelihood of the surrounding cells to take up that antigen, thereby producing more of these vaccine-specific immune cells and increasing your immune response. The Fluad, or the adjuvanted vaccine, works by having a standard dose of the vaccine and then the adjuvant surrounding the antigen that helps to recruit more immune cells. So we have one vaccine that works by increasing the likelihood of uptake, and another that works by increasing the number of cells surrounding and therefore increasing the likelihood of uptake that way. So you're getting more of what is present being taken up. And then by that, it's producing more vaccine-specific immune cells, and then that greater immune response compared to a standard dose QIV vaccine. Now, I will just focus a little bit around the Fluzone High Dose vaccine and some of the clinical data around that. So the concept of having that increased antigen was first developed back in 1996. It was then registered in the US in 2007 and in Canada in 2015 and Australia 2017. And it was fast-tracked onto the NIP along with the Fluad in 2018 in response to that severe 2017 season. And so what was found in those early studies was that by increasing the amount of the hemagglutinin antigen present in the over 65s, there was a greater immune response. So following its registration, there was a very large pivotal study that was done within the US that included over 32,000 patients. And in addition to that, there was a number of independent studies that were done. There was a clustered randomised controlled trial of the Fluzone high dose within nursing home setting within the USA and Canada. And there were a number of real-world studies that were done. And there are ongoing studies as we speak as well. So I'll just briefly go through these. So as I mentioned, this large study that was post its registration that involved around 32,000 participants was across 2 seasons and looked at how well the Fluzone high dose vaccine worked against preventing laboratory confirmed influenza compared to the standard dose unadjuvanted trivalent vaccine. And also serious events related to influenza in a post hoc analysis and the safety surveillance. So within this study, it was found that increasing the amount of antigen, so in our high dose influenza vaccine, there was a 24% relative efficacy in preventing laboratory confirmed influenza in the over 65s compared to standard dose TIV. And this relative vaccine effectiveness was not affected by increasing age. So in fact, as we got even, the people involved in the study got even older, so over 75 years, there was an increase in that average point estimate, although there's no significant difference between these two numbers. But it's highlighting that with that aging of the immune system and that further decline in their ability to respond to new antigens, increasing that antigen content is still having a greater effect in generating an immune response. Now, as I mentioned, that study had a post hoc analysis which saw some of the most striking results for the over 65 population. And so that found that compared to the standard dose unadjuvanted TIV, that the high dose influenza vaccine, it had a significant reduction in all-cause hospitalisation, and notably it was associated with a 40% reduction in pneumonia. So when we consider the number of deaths in the elderly population due to pneumonia and how there is this large underreporting as well that occurs in deaths of pneumonia in individuals that would have previously had influenza, the impact could be quite larger than is actually captured within this controlled trial. So there is also 18% reduction in association in reduced serious cardiorespiratory events. And this was independent of there being any difference in pneumococcal vaccination. So individuals in both the standard dose unadjuvanted TIV group and the high dose group both had the same coverage in pneumococcal vaccination. And interestingly, correlating with that association in reduction in cardiorespiratory events and pneumonia, there was actually a significant difference in the number of serious adverse events in the high dose group compared to the standard dose TIV group. And I'll just say, I don't think that was statistically significantly different, but there was that reduction there. I'd have to recheck that, sorry. In regards to local and systemic adverse events, so as we are getting that increased immune response, there was, and has been reported, an increase in local reactogenicity. So there is increased in those local adverse events. With regards to in this nursing home setting, so this was an independently done study of clustered randomised controlled nursing homes, 823 across the US. So this is where one nursing home received only the standard dose, unadjuvanted TIV, and another nursing home received only the high dose TIV influenza vaccine. And so you can see that goes across the whole of the US. It involved 53,000 residents, so it's quite a large study. And this looked at the relative effectiveness of high dose versus standard dose against hospitalisations in the over 65 population. And so when we looked at the primary endpoint within this study, respiratory related hospitalisation, the relative effectiveness of high dose compared to standard dose was around 13%. And when looked at the secondary endpoints, there was a 21% reduction in pneumonia hospitalisation and 9% reduction in all-cause hospitalisation. So we have a separate independent study that's showing similar percentages in reduction in some of these severe complications. Now, two of the large studies that are real-world cohort studies that were done by the Centre for Disease Control and Food and Drug Administration within the US confirm the effectiveness of this vaccine within the real-world population. And these are quite impressive because the first study involved 2.5 million people, and then the second study, which built on this first one, consisted of 6.1 million people. These are very large studies that were done in the US, looking at Medicare beneficiaries and data linkage analysis. So in that first study, the endpoints were probable influenza and influenza hospitalisation. So in this real-world analysis, these independent organisations found there was a relative effectiveness of 22% for both of these endpoints. So a relative effectiveness against probable influenza and influenza hospitalisation in over 2.5 million over 65 people receiving a high-dose vaccine compared to standard dose unadjuvanted vaccine. And when we looked in this second study, where the population numbers increased to 6.1 million, we have 3 times the amount of participants, and the endpoint is post-influenza death. The relative effectiveness of the high-dose vaccine compared to the standard dose was 24%. And so this is against post-influenza death. So this is a very, very large population, and that's a very, very striking number. So I hope this gives an example as to how having age-specific vaccines for the over 65s can result in greater benefits in this age group. So it's not designed to complicate you or to make providers' lives difficult. It is to have a greater health benefit for that over 65 population. And as I had mentioned, the effectiveness or the over 65s have the greatest burden of disease from the influenza A H3N2. And so this high dose vaccine, when we break down that second study that was done by the CDC and FDA of 6.1 million people and looked at the effectiveness in these 2 different seasons, one being a H3N2 predominant season and the second being a H1N1 predominant season. We can see that in this first year where we had the H3N2, the relative vaccine efficacy for preventing mortality in this season was 36.4%. So there is a greater protection against the strain that causes the most disease within that over 65 group. And so that's something to communicate with your patients when they ask about, but what about this other 4th strain? What am I missing out on? The focus of these vaccines is to give the greatest protection against the strain that causes the most likely to cause the most disease for them. So briefly, what is the update to 2019? As I mentioned, both of these vaccines were made available last year in a 50-50 split on the NIP in response to the public health crisis in 2017. Now, if we look backwards in terms of vaccine policy and practice for our over 65 population, national funding across all states and territories for the over 65s was only brought in 1999. So that was 20 years ago. As Angela touched on, there were some changes in terms of we had the QIV introduced in 2015. Then we had this severe season in 2017 where we had over 1,000 deaths in the over 65s. We had the 2 new TIV vaccines for over 65s brought in 2018. And now this year, our 20th anniversary of the introduction of funded influenza vaccines for the over 65s. We only have the adjuvanted fluad on the NIP for this age group, and the Fluzone high dose, which contains the 4 times the amount of antigen, is available on private script only. So just to summarise, influenza is associated with serious complications that can be prevented with vaccination. An increasing awareness in your clinic and with patients about these serious complications, and that influenza vaccination is not just about preventing influenza disease, it's about trying to prevent the likelihood of exacerbation in pre-existing disease or the likelihood of one of these serious complications occurring is a very important message to try and get out into the community. It's about preventing hospitalisations and death that may occur as a result of an influenza infection, especially when we don't know the true burden of influenza, because there's not often that link between having influenza infection, say 1 month, and someone unfortunately suffering from a heart attack in another month. We don't have that direct link with every case. So over 65s, they have an ageing immune system that reduces their effectiveness to the standard dose vaccine. So that's the vaccine that's unadjuvanted, just containing that 15 micrograms. So that QIV that the rest of the population is getting. And so just to highlight, in terms of those vaccines for the over 65s, some of that data I showed was just demonstrating that the high-dose vaccine has potential to reduce influenza burden in this over 65 population. And with that, I'd just like to say thank you. And if you have any questions, I'm more than happy to answer them, either here or to have a quick discussion afterwards or outside of this meeting also. So, thank you very much. As Angela said, everyone is still waiting on the ATAGI guidelines as to when immunisation should occur. So as per the product information, what is stated within our information is that it's only once, our guidelines based on that is 1 vaccine per year, like within any season. And going through what the authorities say, so such as the ATAGI, is that it should be in line with the peak of, provide the greatest protection for the peak of the influenza season. So generally, the greatest protection is 3 to 4 months after influenza vaccine. And so that's usually in line to be around July, August. That's that time. Angela is more than welcome to touch on that further.
But also the TIVs haven't shown to wane at quite the early stage. So the QIVs tend to, they start to wane around about that 3 to 4 month mark. So it doesn't mean immunity goes away. It doesn't completely go, it starts to wane. But the TIVs actually have some better data pharmacists don't look as though they're going quite as rapidly. But certainly we've got to be responsive to what's happening at the moment, and like I said, for South Australia, we've certainly started vaccinating a lot of supplies in response to the outbreak that we've got at the moment.
Yes?
Why do you think that the government chose to consider Newbound and not Newbound as well?
So I don't know the exact reason as to why that is. We had, as a company, put in a major submission to the Pharmaceutical Benefits Advisory Committee to have our vaccine on the NIP, and that was rejected. One of the reasons was opportunity cost. So a similar reason of rejection was given for one of the GlaxoSmithKline products recently. Opportunity cost can be viewed as a return on investment for the money that they're putting forward. So if they put money to that program, they can't put it towards another program. The exact reasons as to why the government made that decision, we do not know. We are in continuing discussion with the government to try and ensure that every Australian over the age of 65 has a choice and access to that vaccine freely. What will happen in 2020 going forward, we don't know. There is a public consultation document from the Pharmaceutical Benefits Advisory Committee available if you want to look that up.
Last year, I'm from WA. Last year we had a lot of problems with data that well group, that younger cohort, not going to air because the pharmacies who were giving the majority of that age group vaccines didn't have access to uploading data to air. Do you know if any of that's been rectified? I'm assuming we're not the only state to have that problem.
Yeah. So the AIR have certainly been in consultation with Pharmacy Guild, and Guild Care now submits data to the AIR, just like Medical Practice Software does. About 80% of pharmacists in Australia use Guild Care, so there is still a certain percentage of them that don't use that particular software. However, like every other provider in Australia, they are highly recommended to put data onto AIR and do it manually if their data doesn't transmit electronically. But there's no actual legislation written around that as a provider, you must put data on the air. So we can't use that, you must do it. It's just a highly recommended, and we give them all the reasons why. But there were certainly issues also last year with medical practice software not updated to accept the data as well. So there were different updates to medical practice software, and some data was going through and other data wasn't. So, the register is only as good as the data it receives, but if there's roadblocks in getting that data for whatever reason, then it does cause a bit of a problem. But things are improving at least.
Yes?
Yeah, okay, so reasonably comprehensive training. So the nurse, we're certainly here in South Australia, I'm going to speak with South Australia at the moment, but here the pharmacists have to do an online course that's designed by SA Health. So they do the online course. They also need to do anaphylaxis training, which is an online program as well. They need to then go off and do their first aid certificate and basic life support CPR certificate as well, and then attend a 5-hour face-to-face immunisation workshop where they are competency assessed in giving injections. So they inject into sponges, intramuscular as well as subcut, and then they actually give each other an injection of normal saline intramuscularly and also one subcut. So they actually can feel it going through a human skin, not just into a sponge. So once they've been competency assessed and they've completed all of their other coursework, then they can register as an authorised pharmacist. So it's pretty comprehensive training that they have to go through. Yeah, if somebody's actually had an anaphylactic reaction to a flu vaccine previously, or to a component of the flu vaccine, absolute contraindication. For egg anaphylaxis, it's not a contraindication. So if they've had egg anaphylaxis, they can have the vaccine, but it's recommended to be in a supported environment, such as a hospital where there's a crash cart on hand. But the amount of egg protein that's actually in the vaccines is so little that they really aren't seeing any egg anaphylactic patients having an anaphylactic reaction to the vaccine.
I'm from South Australia. My doctor's surgery is attached to one of the nursing homes that has the outbreak. We've got about 18 or more but the care manager was told that we were getting the flu vaccine, so the captain was going to give them a vaccine, which I since got both flu vaccines yesterday. A little dilemma, but there is so many people under 65 in the nursing home.
Yes.
So I can't give them one.
No, not at this stage. You certainly can't. So it is only the flu vaccine arriving on your doorstep at the moment. But as I said, SA Health just sent out that notification on Friday afternoon in regards to that you're starting to order your other vaccines as of Monday. So it depends on when your delivery is likely, 2 weeks time. Yeah. So it is that. It's just, you're just caught in the middle of the big blue sea really at the moment, but we can only do the best that we can do with what we've got.
Okay, does anyone have any further questions? Just out of interest, how many of you have had patients already asking about influenza vaccine? Okay. All right. Okay. Okay. With that, I will just say thank you and pass it over.